Hi, everyone. So just so you know which one of us is which, I'm Dr. Stakelin, and this is Chlodys. So I'm going to go first. I think, is Dr. Stack still here? A lot of our talk is some of the same stuff that he had. I'll try to skim over that. Great minds think alike, I guess, on that. So let me get ahead here. So I'm going to start a little bit with the cost of diabetes, talking about our statistics. So I think a lot of people understand that having diabetes costs a lot, but when you really look at these numbers and the total cost of diabetes being $327 billion, and that it's been a huge increase over the past 5 years, a 26% increase, to me that is a staggering number. And when you're talking about under-resourced areas and under-resourced people, and you look at that, that's just amazing to me. When you break that down, most of that is a direct medical cost, $237 million for direct medical costs, but $90 billion is just reduced productivity. So you can't go to work, you can't provide for your family, you have a non-healing ulcer, you have retinopathy and you can't see, or you have to go to dialysis 3 times a week. And so now there's all this lost productivity as well. If you have diabetes, so it's 2.3 times higher for people with diabetes than people who do not have diabetes when you look at their average medical costs. And care for diabetes is 1 in 4 healthcare dollars in the U.S. That's another staggering one to me, just the cost of all of this. And per Medicaid claims data, the diabetes was the second most costly chronic disease. So you guys have probably seen this map before, something similar to it. So the red outline is Appalachia. It goes up further north than I think a lot of people realize. But if you look at these shaded areas, that is what is defined as the diabetes belt. And so if you look at the number of counties in the diabetes belt that are also in Appalachia, and then you look at our state and the eastern half of it, you can see how prevalent this is. You've already heard that we're the 5th highest state for the diabetes rate in the United States. So residents in these counties are 1.4 times as likely to have diabetes than in non-Appalachian counties, and there's a 1 in 5 prevalence for people over the age of 45. When you break it down into Kentucky, you heard some of this earlier from Dr. Stack, but 12.5 is the diabetes rate for Kentucky, and in Appalachia it's 17%. And when you look at the national average being 11%, I mean that's pretty significant. It was primary diagnosis for about 11,545 hospitalizations, and that was back in 2019. So I don't have more recent stats, but when we know the growth rate, you can imagine how much more it is now. And then in 2021, we had 100,000 more Americans die from diabetes each year, so like for 2 years in a row, than what we had been having before. So that's an increase in 17% in 2020 and an increase in 15% in 2021 compared with the pre-pandemic numbers. So I think COVID, some of those healthcare problems that people had getting to their health care and some of the socioeconomic things that impacted us became even more pronounced during the COVID pandemic. So some of the challenges to diabetes care in Appalachia, so higher health disparities, which we've heard from a couple of our speakers, lower household incomes and higher poverty rates, lower health literacy, fewer healthcare providers, higher food and housing insecurities, which we just heard about, higher than average diabetes complication rates, higher mental health diagnoses, and more fatalistic attitudes. So that's well, I'm going to have diabetes anyway. Everybody in my family had diabetes, and so there's really nothing I can do about it. That kind of attitude, and then less access to advances in technology. I really like this slide. This was an article I read where it talked about how diabetes is not just a chronic medical problem anymore. It's actually a major public health failure. Particularly since type 2 is largely preventable. And so if you think about all the advances we have now and all the new medications we have for diabetes, and we're still looking at these tremendous rises in number of people with diabetes, number of complications and costs, then I really liked this quote that this will not be cured or controlled with medical therapy alone. The number of people with the disease continues to rise at an alarming rate despite huge increase in spending on new treatments. So it's not just about medications and treatment. So in the meantime, what can we be doing? You see these stats and they look pretty dismal, but we can't just sit around and do nothing. So what can we be doing? And at Barnstable Brown, we will always answer that question with education. We are very passionate about diabetes education. It's why I do what I do. It's why Chlodys does what she does. And so I thought we could take a moment to kind of break down. Let me ask a question though. How many certified diabetes care and education specialists do I have in the room? Okay. So I was afraid everybody was going to raise their hand and then you would be like, not needing to see these next few slides. So I'm actually glad to see there's not all that many. So I thought we would show you a little taste of what a diabetes care and education specialist can do with a patient. And so is anybody familiar with DSMES? Does everybody know what that stands for? It's diabetes self-management, education, and support. And so the ADCES has 7 self-care behaviors that you can use as a framework when you're trying to educate someone with diabetes. And so it's an evidence-based, outcome-driven framework for patient-centered diabetes care. There's standardized terminology, it's common language, it's an easy way to communicate, so you are not having to come up with all of this stuff. It's been done for you, it's out there, it's published, it's standardized. And those 7 self-care behaviors are healthy eating, being active, monitoring, taking medication, problem solving, healthy coping, and reducing risks. So we're going to just really briefly hit some items on each of the 7. This was actually part of a much longer talk that I've given before, and I've taken out lots and lots of the slides, but we're going to at least hit a couple high points for each of the behaviors. So healthy eating, we've just heard about food as medicine. I love food as medicine and that alliance at UK Healthcare, so thank you for sharing that. So we're actually trying very hard to get a teaching kitchen at UK to be able to work on some of those things. But so when you think about the goals of healthy eating, a lot of times I'll have patients say to me, well, I know I'm not supposed to eat anything sweet. I know I'm not supposed to eat anything white. And I'll say, what? Who told you that? And, so they think rice, pasta, white bread, when in actuality, we want them eating a wide variety of foods and not just limiting their scope and thinking they can't have anything to eat. We want nutritionally dense, colorful foods, fruits, vegetables. I have people who think they can't eat fruit if they have diabetes. None of that is true. But you do want to think about, reducing sodium and sugar and saturated fats and appropriate quantities of foods. There is a medical nutrition therapy that's diabetes specific. It's a part of the overall standard of care for the ADA. And you can tailor this to personal food preferences and their financial circumstances. So when we, after the conference is over, we're actually going to ask if they can email you out a resource sheet that we've created. And on there are even some pieces of literature about shopping for healthy foods at the Dollar Tree. So what can you find if you are in a food desert and you don't have a grocery store? Here's the list of things that are usually at the Dollar Tree that would be on the healthy eating list. We like to teach food label literacy, just the basics, like here's how you find how much calories, here's the percent of fat, here's the number of carbs, just the very basic things on food labels. And then we've realized that tracking and monitoring what you're eating gives people an awareness and accountability, and it's actually a predictor of long-term dietary change, something that they'll sustain. We are big proponents of the diabetes plate method. Has anyone ever seen this? So if you think about like the kid plates with the dividers, so half of your plate should be all your non-starchy vegetables, all those colorful things, your leafy greens, your peppers, your onions, all those non-starchy ones. And then the other half is divided into quarters, and you've got your protein in one quarter and you've got your carb in the other quarter. So people who think they cannot have any carbohydrates, they can never eat a potato, they can't have any rice, that's really not true. They just have to do this in moderation and with portion control and with a nice balanced rest of their plate. And you can, this is something else on our resources sheet, but you can Google this. There are diabetes plates for all different ethnicities. There's a Southern style diabetes plate. There's a Hispanic diabetes plate. You can find them for all different ethnicities as well. So another one, being active. So has anyone heard that sitting is the new smoking? Has anyone heard that phrase yet? So we are also sedentary now, in whether it's being at the computer, being in front of a screen all the time, or COVID happened and we didn't work anymore, so we stayed home. We're just less active in general than we used to be. And so I'll have patients tell me all the time, well, you know, I have arthritis in my knees, or I've had my hip replaced, or I have COPD, and so I can't get out there and exercise. And so I've learned that patients' connotation of what exercise is or what being active is like running a marathon or a 5K or something. And so I tell people all the time, I just want you to move more than you move now. That's what we're trying to accomplish here. And so you can just decrease the time that you spend sitting. You know, can be for all fitness levels. This doesn't just have to be for people who are already fit and can do those 5Ks. You do need to think about, does someone need medical clearance first, or any of those special circumstances, like if they have retinopathy, their blood pressure shouldn't go up really high with their activity. And if they have autonomic neuropathy, maybe they need to warm up and cool down more than the average person would. Or if they can't feel their feet, they need to be checking their feet before and after exercise. Maybe if they have a foot ulcer, they shouldn't be bearing weight on that ulcer right now. And people with vascular disease might have to limit the time or the intensity, but there is something that everyone can do. And then, of course, we want to talk about hypoglycemia with exercise with our patients. So for my patients that feel like they really can't do anything, I one day, just out of curiosity, sat down and Googled indoor walking and chair exercises, and literally got over 11 million hits. So there are countless things that people can do from their chair in their home that are free of charge and do not require them to have a gym membership or be able to run down the sidewalk. One of the favorites that I saw was something called Leslie Sandstone's Walking Down Your Blood Sugar, so particularly for people with diabetes. I think, is this where I'm turning it over to you? We're going to trade out for a minute. No? Okay. Okay, just kidding. So patients need to know not only what they need to monitor, but when and how to monitor that thing. So it's very individualized. Some patients need to monitor their blood glucose once a day. Some people need to monitor it 4 or more times a day. Some people also need to monitor their blood pressure or their daily weights. So you've got to sit down with your patient and let them know what it is you want them to know, why you want them to know it, and how often you want them to check it. This kind of reinforces some of the other self-care behaviors that we're going to be going through, because, you know, if we want you to monitor your weight, then that has to do with increased activity. If we're monitoring carb intake or calorie intake, that's healthy eating. Monitoring when you take your meds, monitoring your blood glucose for risk reduction, so you know what makes your blood glucose go high and what makes it go low. There are lots of reasons for monitoring. For one, just to identify trends, but also to help them problem solve, which is actually one of the self-care behaviors. Obviously for safety, because if they're having blood glucose readings or low or high blood pressure readings, you would want to know that. Obviously so they can share it with you as the provider. And I would encourage you, if you actually are a provider or an educator or someone who sees patients with diabetes, even a family member, if you've got someone who is willing to check their blood glucose readings, there is nothing more discouraging than for them to bring it into the office and it be brushed aside or put away or not reviewed. So, you know, kudos to them for doing it. So give them lots of encouragement and take the time to review it with them if they've taken the time to do it. But you can use those readings for goal setting, and it just reinforces positive behavior and cause and effect. So, hey, if you're not sure how a certain food what it's going to do to your blood glucose, then check before you eat that thing and check again an hour or two after and see the difference. So that cause and effect reinforcement is very helpful and a good reason for monitoring. Okay, now we're trading.
Alrighty, so I have the latter half of the self-care behaviors. First one I've got is taking medication, and I'm going to give a disclosure really quickly. We said no disclosures. I'm very audience driven. I used to, before my bio was written, I used to teach middle school. So at this point, like if I wasn't pulling you guys in, you would be fist fighting. So I'm going to start calling people out, and don't feel embarrassed. We're all here to help patients. So my first self-care behavior that I'm talking about is taking medication. So there's a lot of barriers to patients taking their medications from diabetes. One of them is cost. So copays are high, deductibles are high. Sometimes people just lack insurance. There's coverage gaps. Formularies are constantly changing. So while you might have written your patient the correct script a month ago, maybe their insurance renegotiated with the pharmacies and now it's no longer covered. Patients are often rationing meds, so you'll hear people say patients are not compliant with medication. It's not a great term because sometimes they would be compliant if they actually could get the medications they needed. So it's really important to ask non-judgmental questions regarding medication adherence. Are you taking your medication? Is there any reason you can't take your medication is a great way to phrase it, because there's often a lot of reasons people can't take their medication. Maybe it's actually making them physically ill and you just haven't gotten to that. Local health departments have resources. We have some resources in our guidebook, but I think kind of talking with your patient and finding out, are they taking their medication? Often for patients, particularly with type 2 diabetes, we're recommending 3 and 4 medications before we start on insulin. That's what the ADA standards of care have us doing. And some of those medications are incredibly expensive. There's other barriers to adherence, mental health, side effects. Maybe patients aren't seeing a difference in their glucose. Work schedules may be changing. I think that complex dosing can often keep people from doing it. Vision and dexterity issues play into it. And I think where the role of education really comes into play, how many of you guys work in primary care? I see one hand. How many people are a provider themselves in primary care? Okay. How long is your normal appointment? Oh, I saw 2. How long is your normal appointment for a follow-up?
15 minutes.
15 minutes. What about you? 15? Are they double booked? Ever? You do wound care, so thank goodness. What about you? Are they ever double booked? Sometimes. Often. Okay, so in 15 minutes for her or him or whoever that person may be, it's really hard to get down to looking to what is that barrier to adherence. So the advantage of having a diabetes educator or referring your patient to a diabetes educator is that that person has the time. It's not that our primary care providers or even our endocrinologists don't know these things or preventing, but it is a time factor. So I worked in primary care before I did endocrine specialty care. Same with problem solving. So problem solving is one of the self-care behaviors. So can you teach patients to problem solve? So the thought process in solving the problem is something that we can teach people. We can teach them to go through those cycles, think about strategies for finding the resolutions, selecting the most appropriate strategy, applying the strategy, and evaluating how effective it is. So if you come into one of our DSMES sessions, diabetes self-management education sessions at Barnstable, you will often see the educators working with the patient individually to kind of coach them through potential scenarios. So while you may prescribe a medication in a clinic, what's that patient going to do if they forget their medication, if they start learning their medication is lowering their blood sugar too much, perhaps on the day they go to cardiac rehab. So a lot of this is solving the problems related to medication taking, and that just takes time. In a 15-minute visit, we often don't have time to create scenarios. We are dealing with the scenario at hand. So it is an essential skill for diabetes self-management. He uses problem solving as a strategy for goal setting and attainment, as well as skills attainment. Recommended part of all DSMES curriculum. So I do think it is one of the more important self-care behaviors, and it's because it can really incorporate everything else. So you were talking about food insecurity earlier. Great talk. So what does your patient do when their food box runs out? So maybe their medication was appropriate 2 weeks ago, but their medication dose may not be appropriate once they have lower resources. We don't want to think of our patients living in that space, but unfortunately they often do. So problem solving can really influence each of those. Healthy coping. You guys all know, because you work in the healthcare space, diabetes is any chronic disease is a hard thing to deal with. So healthy coping is one of the self-care behaviors. So it's defined as a positive attitude towards diabetes self-management, positive relationships with others, and quality of life. It's crucial to navigating the other 6 behaviors, and ongoing support is so critical. Diabetes education actually changed its name and went from self-management education to self-management education and support for that reason. So I loved hearing about the support groups we have in our ARH groups. I actually talked to somebody from Pikeville earlier, and they were talking about their support group. So it's so important that we are giving patients the resources to cope, and their families, with this chronic disease. In Appalachia in particular, and with people with diabetes, there's high levels of anxiety and depression and other comorbid health conditions. People can also feel feelings of fatalism or helplessness. It is a chronic disease. We tell our patients it is often not going to go away. That's one of the biggest things people ask me when I see people for consults in the hospital that learn they have diabetes when they're shipped to the big UK. Is this going to go away? Can we fix it? Can we put it in remission? Perhaps with some dietary changes, but I say, no, it's not going away. It's something that we're going to learn to live around. Dr. Stakelin had these slides from her previous talk, but it talked a little bit about Appalachia having higher, people in the Appalachian region having higher rates of somatization, which can lead to self-medication, substance abuse. There are more problems with a scarcity of mental health resources and providers. I'm from the other end of the state, so I'm from as far west as you guys are east. I'm from Paducah. And there is also a mistrust of mental health resources, or a big stigmatization. So back in my county, you don't go see a mental health care provider because your business is everybody's business. How many people hear that often? So people don't talk about that sort of thing where I'm from. There's also mistrust of outsiders due to years of isolation. Same stereotypes from my part of the state. I was once told when I came up to Lexington that I had that Midwestern mistrust of people. So apparently the ends of the state were kind of extreme. Providers often also experience negative emotions, fatigue, frustrations, and often feel overwhelmed by their patients' fatalistic attitudes regarding diabetes. We talked a little bit, about resources. I see some people taking notes. ADCES is the organization associated with diabetes educators. On our resource list, there is a link to a tip sheet for all of these 7 healthcare behaviors. These are fantastic. I don't know how many of you guys have people in your healthcare organization that say we have no budget. This is a great no budget way. You do need to be able to print these, or you can even get a QR code for your patients. But 7 healthcare behaviors, great tip sheets for patients that you can post in your office, that you can share, all for free. The next behavior I'm going to talk about is reducing risk. Dr. Stack reminded us early this morning that the best risk reduction is total prevention. So we need to be screening in primary care spaces for those that don't even get to primary care, in community spaces. When people have the diagnosis of prediabetes, letting them know at that point, we do have ways to prevent diabetes, connecting them with our local health departments or our private health systems diabetes prevention programs. When people are diagnosed, or when there is any change in that patient's level of health, or even on a yearly basis, referring that person to diabetes self-management education and support to really help them work through that disease process and prevent risks and complications in the first place. And reminding our patients that when you do see signs of risks or complications, go ahead and talk to your primary care provider. And there are all sorts of risks associated with diabetes, unfortunately. You want to be working with patients to think about how to deal with hypoglycemia, how to deal with hyperglycemia, the risk of diabetic ketoacidosis, which is a complication of insulin deficiency, often associated with medication non-adherence or non-compliance, sick days, is talking to patients about where to get their annual retinal scans. If you can do it in your primary care office, what a great opportunity. Talking to them about kidney risk, how to control those risks by monitoring blood sugars and managing them, and monitoring their blood pressure and making sure that's controlled. Talking about foot care, and obviously about cardiovascular health. So really quickly, we're going to talk about BBDC. So Barnstable Brown Diabetes Center, we actually are very lucky to have a number of diabetes educators. So I saw 3 CDCESs raise their hand in here. How many people are holding an apprentice educator license or an LDE at this point and are working towards their CDCES? I see several hands, and that's really exciting. That's where we want to see more people. Even in Lexington, we're having trouble finding diabetes educators, and so it is so important that we encourage our nurses and dietitians, even our health system, to support people going on to get their licensure. So we are lucky to have all of these folks. We have an arm of educators, Andrea and Angela, who work with pediatrics, with diabetes in our endocrine group. They actually do some health mobile clinics in your own communities for pediatric patients with diabetes. Our adult team is supported currently by 3 diabetes educators. 2 are CDCESs and 1 is still working on her licensure. She's an LDE. And they're really at the elbow support for our clinicians in clinic. And then we have an education center where we're running a DPP program, DSMES program, and then we're doing training on a number of different types of pumps and sensors, including Medtronic's pump back there. So we are very resource rich in terms of CDCESs, but we need them all through the community. One of the great things about the conference today is I've gotten to meet educators throughout the community, and when people come to UK in the hospital and say, hey, I'm not going to be able to get back to Lexington, I can now say, oh, I met this person, Ashley, she's really fantastic, we need to get you in with her. People often trust people from their own communities more than they do some random stranger they met on one of the worst days in their life. So. Education services at BBDC, this is just talking about our DSMES program, so our diabetes self-management program, and it's talking about the different types of services we've offered over the last year. So the tallest bar is pump and sensor education, so we've been seeing a rise of number of people wanting to use diabetes technology. On the left, you can see we've had quite a few people also doing diabetes self-management education. We have other people doing diabetes prevention programs. We have gestational, and we have MNT. If you do not have resources in your community, Barnstable does have web-based telehealth services for all of our types of education and are happy to accommodate your patients for certain. And we have a physician liaison from UK who can help you set up referrals to our center if that's something that you want. So I think Dr. Stack and a couple of other people have talked about A1C lowering. So the average pre-program A1C for people in our DSMES program last year was 8.67, and the post-program A1C was 7.56. I think what's really cool about diabetes self-management education is there's no negative side effects like there are with medication. It is often a 1 or 2 time cost when you get people in there, whereas a medication you may have to continue forever. So a really great service we can offer our patients. So our final slides, I think Dr. Stakelin and I were going to take on together, but it's education, where to find it, how to get it. There's a lot of resources in the back of the room about things throughout the state. Obviously, we're interested in you guys also coming to UK if that's what your patients want. But we are really encouraging people to train.
I was just going to jump in and say, I used to be on the Kentucky Board of Licensed Diabetes Educators. I served a 3-year term, and when I was there, there were only 120 diabetes educators in our state, so that's literally one per county. But when you looked at who those people were, a lot of them were not practicing as diabetes educators. So like Kroger at one point sponsored any of their pharmacists that wanted to be certified. So those people are obviously not practicing diabetes education. So when you look at the number, it's actually way fewer than one educator per county. And for a state that's the 5th highest in diabetes incidence, I mean, that's really alarming. So, I mean, truly when we say wanted diabetes educators, like this is key. We really want to be encouraging people to become an educator. And so I interrupted Chlodys about what the process is, but I mean, that's another staggering statistic to me is how few we have in the state.
So as Dr. Stack said this morning, in our state, we do have the requirement that to call yourself a diabetes educator, you need to be either an apprentice educator, which means you're just getting started, an LDE, or an MLDE once you have your CDCES. But at the national level, there's kind of 2 ways to go about getting diabetes education certification. So there's the CDCES route. And so essentially you have a primary licensure, and then you're accumulating 1,000 hours of diabetes care and education with patients. You grab 15 hours of CE that are applicable to diabetes. If you have a primary licensure, you're probably getting those 15 hours somehow anyways, so double up if you can. And then there is a CDCES exam that's offered, and there's a link on becoming certified. You can also get a BCADM, Board Certified Advanced Diabetes Management credential, in addition to your primary licensure. And so there's information about how to go that route. So again, you need a primary licensure, and then you get credentialing with hours and an exam.
And we'll have this on the resource sheet that we send out. So.
Additional great resources. So even if you're not going to pursue a licensure, but you'd like these things to be incorporated into your office, there through ADCES, there are great courses on the 7 self-care behaviors. Those do cost something, but as I said, there's some really great tip sheets on them for free. Core Concepts course is a great course by ACDES if you're studying for your licensure exam. And there I spoke a little bit to Indiana and Kentucky requiring licensure for an apprentice. Plugging other resources, and we talked a lot about DSMES. If you're somebody, we talked to someone in the audience earlier who is just starting at a health department. If you're interested in offering DPP, the State Department of Public Health will often voucher your lifestyle coach training when they have that available. So that's a great resource to look into as well. I'll let you take over from here.
Okay. So a lot of times people say, well, how do I know if I have an educator in my area or an education program in my area? So I really just went kind of scouring through my resources and have put on here different places where you can look for a certified diabetes care and education specialist in your area. This will also be on that resource page that we're going to email out to everyone. So if you are hunting for someone or for a program, these are some places that you can look. And I think that is it. Anyone have any questions? Okay, we'll be here for a little bit longer if anyone thinks of anything. So, thank you.